I'm talking today with Dr. Chris Davey, who is the head of mood disorders research here at Orygen, the National Centre of Excellence in Youth Mental Health. Thank you for your time, Chris.
Oh, good. Pleased to talk to you.
Now, you've co-authored a For Debate article for the 16th of May MJA on antidepressants. And basically, it's not a very pretty picture, is it? We don't think that you're finding that they're not as effective as we once thought they were. And what does that mean in terms of the care we're giving to people with mental health issues?
Yeah, well, that's right. It is a slightly concerning picture in that, we rely on antidepressants as our main treatment for depression in Australia. We, prescribe more antidepressants than almost any other country in the world. But the more we get the research findings that collates all of the different studies into meta-analyses, we find that the medications aren't really that effective.
Why are we prescribing them more? Is it just an easy solution in many ways?
I mean, we can only speculate. I mean, I suspect that's partly it. Depression is a really common problem.
Yep.
People are possibly more likely to seek treatment for their depression. I think, as a really positive part of all this, there is less stigma now than there used to be.
Mm-hmm.
And I guess the thing that doctors think about first in treating depression, for better or worse, is antidepressant medications.
Yeah.
And look, and part of that is because they were heralded as this great treatment for depression. There was a huge marketing effort.
Yeah.
I mean, early studies were really promising. These seemed to be really good treatments. But as time has gone on, we realise they aren't as good as we once thought. They're also not as bad as our critics. The critics might suggest they are.
Yeah.
They're not absolutely useless, and I think that's important to emphasise.
Is it a diminishing effect?
That is really what they're recording for the antidepressants, a diminishing effect, which isn't unlike other treatments in medicine.
Yeah.
Over time, there tends to be this trend to show treatments become less effective.
Is that a placebo effect happening there?
So for depression, it does seem to be the placebo response is a part of it. I mean, there are a few reasons. I think, one of them is that, and especially in the past, trials with negative findings weren't published.
Yeah.
So there's the file drawer problem where the negative trials were buried. But, they've been uncovered now because they generally are registered with the regulatory bodies and people have been able to find them. And when you include that data in the analyses, you can, it obviously reduces the effects of the medications.
Yep.
I mean, a second reason, and again, common to other treatments in medicine, is that the earlier trials tend to be sort of more conducted in more highly controlled environments,
right,
where you get these sort of fairly middle class, uncomplicated, motivated patients to enrol in your trial.
So the real world effect is
that's
less.
right. And then as time goes on, you roll out the studies into the real world populations, like you say, who have comorbid problems with anxiety, excessive alcohol use, all the stresses and strains of life, and they don't tend to do as well. And then, I think in depression, it seems to be particularly sensitive to the placebo effect. And the placebo effect does seem to be getting stronger in depression.
Okay.
And why is that so? And it's a good question. So I guess the placebo response has a couple of components. One is this regression to the mean idea, or this sense that if you get people on first measurement who have a particularly sort of extreme outcome on any measure, then when you measure them the second time, they tend to have returned close to average, and I think that's the case for depression. Depression tends to get better with time.
Yeah.
But there's also this sort of positive expectation bias. That's a big component of the placebo response. Expecting to get better, we know now, is one of the ingredients that helps you to get better.
Yeah.
And I think that's, depression's particularly sensitive to that. And my own sense is that feeling hopeless is a really sort of core symptom of depression.
Yeah.
And any treatment is hope. It gives you hope that you're going to get better, and you're really kind of directly addressing the symptom of depression with the placebo treatment.
Yes.
And people are expected to get better, and they do. But as to why the placebo is becoming even more powerful in depression, well, that's a good question. One theory that I think carries some weight for the placebo in depression is that perhaps this expectation that you're going to get better with medication is greater now than it used to be. I mean, we are sort of all privy to this kind of culture that suggests that we can get better from depression by taking a pill, notwithstanding the evidence that's emerging in the journals, which of course most patients don't read. But there is this sort of cultural sense, I think, that you can get better from depression with a medication, and so people are primed to get better when they're taking a pill, whether it's the medication or the placebo pill.
Is the same thing happening in terms of psychotherapies? Are their effects diminishing as well?
They are. So the psychotherapies, when the earlier trials were published, had these, really implausibly large effect sizes, really, but they were particularly effective. And again, it's that sense that people who have developed the therapies, who are motivated to show they work, who are using the therapies in a select patient group, all these sort of unconscious biases, really, that favour showing that the therapy works. Whereas more recent trials, again, more real-world patients who have more complexity, who are perhaps less motivated, has brought their effectiveness down. The other thing with psychotherapies is, especially with the early trials, they had much sort of looser designs. So for all the criticism you can direct at medication trials, and there are many, they're generally conducted with a fair bit of methodological rigour. It's easier to blind a medication trial than it is a psychotherapy trial. But there was this principle of intention to treat, so you analyse the outcome of those patients according to which group they were assigned, whether or not they actually got the treatment. Which wasn't always the case in psychotherapy trials. There wasn't a high degree of blinding. Often they either got the therapy or no treatment at all. They're often just left on a waiting list.
Yes.
Which are all things that make it much more likely that therapy is going to be effective. But when you do the things you do for medication trials, when you have adequate blinding, where you actually compare the psychotherapy to some other sort of active control treatment, which might be just having someone talk to a research assistant or a clinician for the same length of time each week. When you put all those factors into the trials, and the psychotherapies also, they're still effective, like medications. They're clearly more effective than the placebo treatments, but they're just not really effective.
So the combination of the two, antidepressants plus psychotherapies, is that still the most effective treatment we have for depression?
Yes. I mean, the combination of those two together are at least in adults, clearly more effective than either alone. And I guess that's one of the things that we really wanted to emphasise in this article, that the treatment of depression doesn't start and stop with antidepressant medications. We want to make it clear that it's sort of one component of an overall treatment plan, and that, in most cases really should include a recommendation for psychotherapy. I mean, there are reasons why you might not do that, and a big one is because psychotherapy isn't always readily available.
Yes.
But there aren't very good reasons in most cases why you wouldn't recommend that someone considers psychotherapy, either alone or in combination with the medication. But I think the opposite is more often the case, that it's recommended that people take a medication alone without a consideration of combining it with psychotherapy. So I think, the overall message is to really consider that, medications are one treatment amongst a number of treatments for depression. Look, sometimes they might be effective alone. There are patients who will respond simply to a medication, but there's a large number of patients who won't. And for them especially, it's just to consider the other treatment options. So that would be, principally, I suppose, combining the medication with a psychotherapy and offering, a referral to someone who offers an evidence-based psychotherapy. But it also might include, addressing lifestyle factors, which are obviously germane to lots of illnesses other than depression. There is good evidence that people with depression respond to exercise plans, to eating better. As yet, I'd say the evidence isn't there to suggest that these could be standalone treatments, that it would be enough to do that by itself without anything else, but they can only help when added to other treatments. And then there's sort of emerging evidence that other more benign treatments might help with depression. So adding things like fish oil and vitamin D might augment the effects of antidepressants. So I guess the overall message is to see, antidepressants as one component of an overall treatment plan for depression, and not the be all and end all of treatment.
Terrific. Thank you for your time.
Oh, good. Thanks.